Welcome to the St Emmeline's podcast. I'm Ian Beardsall, and this is another episode of the podcast taken from live recordings at the Premier Conference in Winchester in June 2024. Before we get on to the episode, just a note to recommend the Tactical Trauma Conference, which happens in October this year in Sweden. A strong focus on pre-hospital emergency medicine with some really distinguished speakers. We'd highly recommend you have a look. I believe there's still some tickets available and flights to Sweden from the UK are very reasonably priced. So there's links on the website. Take a look at it. On to today's episode. This is a fascinating episode about something I think we're all going to have to become more familiar with, whether you're in adult, pediatric emergency medicine or both. And this is about hybrid closed-loop insulin pumps. Last year, the National Institute for Clinical Excellence published a technology appraisal, which said that all people with type 1 diabetes, whether adults or children, should have access to this technology, these hybrid loop insulin pumps. And so over the next 3 to 5 years, we're going to expect many people to be on them. We need to be more familiar with this technology and know how different patients may present to us who are using these pumps and how we can best look after them. Nicola Trevelyan is a consultant paediatrician at University Hospital Southampton and a specialist in diabetes, and I'm sure you're going to find this talk incredibly interesting and useful. Please remember, like and subscribe wherever you get your podcasts, and we'll be talking to you again very soon. But now, over to Nicola.
So the biggest challenge for me was always going to be, with this morning's talk, how to condense a topic that I can talk about all day into 15 minutes. So what I thought I'd do is talk instead about an increasingly frequent treatment option for people with type 1 diabetes, which causes a little bit of anxiety, namely hybrid closed-loop insulin pumps. So the outline of my talk, I'm going to just do a really brief recap about insulin pumps and then talk about hybrid closed loops and how they're slightly different. The majority of my presentation is going to be 3 different case presentations that might present to children's ED and how best to manage them. So why do you guys need to know anything about hybrid insulin pumps? Last year in December, NICE published a technology appraisal which stated that all people with type 1 diabetes, adults and children, should have access to this technology. And so over the next 3 to 5 years, NICE wants us to put all people with type 1 diabetes onto these systems. So you're going to be coming across them whether you like it or not. Just a little recap about insulin pumps. All they are is a syringe driver that the patient is wearing that gives a continuous infusion of fast-acting insulin, and the patient is connected to the pump 24 hours a day. They can disconnect it for short periods of time, half an hour if they're having a shower or if they're playing contact sports, but for all intents and purposes they need to be connected to it 24 hours a day because it's only giving them fast-acting insulin. The insulin is delivered via a soft cannula, like a little gel coat that sits in the subcutaneous tissue. It needs to be changed every 3 days, and the patient needs to bolus insulin when they eat food. So they still need to carbohydrate count and then tell the pump to give a little shot of insulin to cover all food. So because the half-life of fast-acting insulin is roughly 80 minutes, it means that if the cannula becomes kinked or dislodged or blocked for any reason, that they will quite quickly run out of insulin because they don't have that safety net of basal insulin that people on multiple daily injections of insulin have. So once that insulin is stopped and they're not getting it, they will very quickly start to get ketosis. So within 4 to 6 hours, their blood ketone levels will be rising, and within 10 to 12 hours, they will be in DKA. So hybrid closed loops are a really clever thing. They have 3 components. They have the patient wears an insulin pump that's delivering fast-acting insulin. They also wear a continuous glucose monitor. So that's measuring their blood sugar every 2 or 3 minutes. And it's measuring not just the blood glucose, but also giving a direction of travel, so whether the glucose levels are going up or down. And that then links with the insulin pump using closed-loop algorithm. You don't need to know how the algorithm works. All of the different systems use slightly different algorithms, but to all intents and purposes, what the algorithm is doing is using information from the continuous glucose monitor and telling the pump whether the blood sugar is going up, in which case the pump will deliver slightly more insulin, or if the blood glucose is dropping, it will deliver slightly less insulin, or even suspend the pump completely for short periods of time. So it's a complete game changer for people living with type 1 diabetes because every 5 minutes the amount of insulin they're receiving is changing. So it's even better than being on an IV sliding scale in its reactivity. There are 2 main different types of closed-loop systems. So there's the patch system, and this is a pump where the pump is actually stuck to the patient and the cannula comes out the back of the pump and is infusing the insulin. So that pump, once it's stuck to the patient, it's stuck there for 3 days. The other system is a tube system where the pump is separate and then is connected to the patient via a wire and a little subcutaneous cannula that they can clip and unclip. The pros of it are that the patient can get really, really tight diabetes glucose control, especially overnight. So if you're asleep for 8 to 10 hours a night, you can absolutely smash your diabetes. They're also very, very good at avoiding hypos, which is the main fear of a lot of people living with type 1, that they hate going hypo. The downside, though, is that these patients are at increased risk of ketosis, and therefore you need to be wary of that. Also, the patients have to be slightly tech-savvy. So what could go wrong with these systems? So there are 3 basic things that can go wrong. Firstly, connectivity issues. This is when bits of the system aren't talking to each other, or a bit of the system isn't working. Now, nobody is going to expect you to be able to sort that problem out, but what you do need to do is recognise that there is a problem with the system and keep the patient's diabetes safe. The second, and by far and away the commonest reason that patients present, is because they've had problems with the cannula and they haven't realised until too late that the cannula has blocked or kinked or become dislodged. And then the third issue is intercurrent illness. So these are kids, the kids get ill, and if you're ill and you have diabetes, it can be slightly more complicated. So the 3 questions I want you to ask if you see a patient with type 1 diabetes who's on one of these systems. Firstly, is the patient in DKA? You need to make sure that they're not in DKA. Have they got insulin on board, and have they got some form of substrate, glucose, fluids, food on board? So my 3 cases. Firstly, 7-year-old girl on hybrid closed loop, presents to see children's ED, always in an evening shift, isn't it, when nobody else is around. And she's got a short history of vomiting, and the parents have said that they think she's got a gastro bug. So what further information do you need? Firstly, you need to know what her glucose level is. And the parents say, well, on her CGMS, her continuous glucose monitor, it's reading about 25. Her sugars have been high all day at school. She hasn't checked for blood ketones because they hadn't really thought to do that, and also they've lost where their meter is. And they've been given correction doses via her pump, but it doesn't seem to be making any difference. So back to those 3 questions. Is she in DKA? Has she got insulin on board? What fluids does she need? This is absolutely classic of a child who's got their cannula blocked or kinked or dislodged. And the first thing you need to do is confirm that her blood sugar is high. So if her sugar levels are high, then you need to check for ketones. And what you do next is completely governed by what the blood ketone levels are doing. If the ketones are low, so they're less than 0.6, you've probably got time to give more boluses via the insulin pump and put in the blood sugar level, and the pump will calculate how much insulin to give to correct the high sugar. If the levels aren't coming down, or in particular if the ketone levels are going up, that tells you that you need to do a set change. You also need to be pushing fluids if the child has been vomiting. If the ketones are moderately high, so between 0.6 and 1.5, you need to give them a pen injection, because the fact that the ketones are going up tells you that the closed loop is not delivering insulin as it should do. So you need to just bite the bullet and take them off that system, give you a little bit of time while they're doing a set change, give them some insulin, so 10% of their total daily dose of insulin as fast-acting insulin. And that needs to be given as a pen injection. And then push fluids and make them change their set, so they're giving set their cannula, the insulin in the system, and recheck their sugar in an hour and ketones in 2 hours. If the ketones are even higher, if they're above 1.5, the first thing you need to check is that they're definitely not in DKA, so you want to do a blood gas to make sure that their pH is normal, and then you're going to give them 20% of their total daily dose of insulin as NovaRapid as a pen injection. So how to calculate the total daily dose? So we're increasingly telling patients, getting them to take note of what their total daily dose is. And for most of the clinic letters from the diabetes clinic, it will state what their total daily dose of insulin is at the top of that letter. However, if you haven't got that information and the patient doesn't have that information, you can roughly work out what their daily dose of insulin will be, because primary school kids need about 0.7 to 0.8 units per kilo per day of insulin. That's their total daily dose. And pubertal kids need a little bit more, usually around 1 to 1.5 units per kilo per day. If you take no other message home other than this, please take this home. Vomiting in somebody who has type 1 diabetes is DKA until you have proven it's not. Time and again, patients are missed and they present to primary care with vomiting, and people always put it down to a gastro bug, or in teenage kids down to a hangover maybe. But if you've got type 1 diabetes, you're much more likely to be vomiting due to ketosis than anything else. And check that they're not in DKA, check their pH is above 7.3, ketones are less than 0.6. So the second case is a 3-year-old boy on hybrid closed loop. He presents to the emergency department, again in an evening shift, again with a history of vomiting, and they're diagnosed with gastrobug. So what information do you want? So this child is slightly different. He's been vomiting for 3 days and keeping very little down. So his blood glucose has been in the normal range until today, when he's stopped really wanting to eat or drink anything. And his sugars are now running low and he's not wanting to eat or drink anything. And when the parents measured his ketones, they're high, they're 3.6. So what's happening here is slightly different. So he has got a vomiting bug, and because the hybrid closed loop is very clever, it notices that he's not eating very much, and therefore his blood sugar levels and insulin requirement have gone down, and it stops delivering as much insulin. So that holds him for the first 24 to 48 hours of having his gastrobug. But then starvation ketones start to kick in, and as his starvation ketones go up, he feels more and more sick and won't eat or drink. And at that point, he starts vomiting more, and you're in a vicious circle which you can't get out of without intervening. The first thing to do is confirm that his sugar is low and that his ketones are high. And if the glucose is low or in the normal range, it suggests that the closed loop system is working as it should do. So the child is still getting some insulin because his blood sugars are low, but not enough. He can't give himself more. He can't have more insulin because he hasn't got enough substrate on board. So what you have to do is give him more substrate, give him more glucose. And the easiest way to do that is to just give him IV fluids, 5% or 10% dextrosaline with a little bit of potassium in. And I would just run that in over a couple of hours. You don't need to work out what his fluid rate needs to be. 500 mils over 2 hours for a child this size will do him no harm whatsoever. And the glucose level as it goes in will start to stimulate the system. The system will notice that his blood sugar is rising and start to give a little bit more insulin. So the combination of giving him more insulin, more glucose and fluids will effectively treat his ketosis. And then as his ketones start to fall, you'll realise that he'll start to eat and drink a little bit more. So the last case is when something goes wrong with the system. So this is a 13-year-old who smashed his pump in a fit of rage. So at this point, there is nothing that you can do to make the hybrid closed loop work. So what you need to do is just make sure that he is safe with his diabetes. So this will involve changing him back onto pen injections. So firstly, does he need fast insulin? So check his glucose levels or check his ketones. If his glucose levels are okay, so they're less than 10, that suggests that he just needs to carry on having pen injections of insulin with food. He doesn't need any other fast insulin at that point. But if his glucose levels are high, you'll need to give him a correction dose of fast-acting insulin just as before. So if his ketones are moderately high, give him 10% of his total daily dose as Novorapid. If his ketone levels are very high, above 1.5, give him 20% of his total daily dose. However, because he can't go back onto the closed loop system because he's broken his pump, you'll need to give him some basal insulin as well. And that you can calculate just as 50% of his total daily dose. So this is why we're increasingly getting patients to make a note of their total daily dose, because in an emergency like this, it can really help guide what insulin, if you need to go back onto pen insulin, to give them. In summary, hybrid closed loops are brilliant and they're here to stay for the foreseeable future. You will see increasing numbers over the next 3 to 5 years. So most people with type 1 diabetes will be using these as their standard therapy. They deliver fast-acting insulin, so when they go wrong, the risk of ketosis and then DKA is quite high. And if they're vomiting, if ever a child is vomiting and they have type 1 diabetes, assume they've got DKA until you've proven that they haven't. They do still need to bolus, though, even though the system is giving a little bit more, a little bit less insulin, depending on what their sugars are doing, they do still need to bolus with food. The commonest problem that they will present with is the cannula kinking, blocking, becoming dislodged. High sugar and high ketones give a pen injection and then get the patient to change their giving set, change the cannula, and calculate the correction dose using the patient's total daily dose of insulin. If they've got low sugar and high ketones, keep them on the hybrid closed loop system, but give them more glucose. And if the system's broken, you just need to give them pen injections of insulin, but don't forget they need basal insulin as well as fast-acting bolus insulin. Thank you very much.